Welcome to the final section of the cardiovascular section. We're almost done. Cardiovascular is heavily laden with heart sounds, of course, and the physiology of those heart sounds. And here we go. A man comes to the office for a follow-up of some long-standing hypertension. And he's asymptomatic, and he's got some hypertensive medications. He's got an extra heart sound. What is it? Well, this extra heart sound is from long-standing hypertension that is caused by, well, you don't have to give extra therapy because you need to treat the hypertension anyway. It's an S4 gallop. An S4 gallop does not need extra medication because you already need to treat the hypertension. So all you're going to do is just say, duly noted, S4, left ventricular hypertrophy, S4, hypertrophic cardiomyopathy, S4, long-standing hypertension, hypertrophic cardiomyopathy, no big deal. It's the sound of atrial systole going into a stiff, non-compliant ventricle. S4 gallops are associated with left ventricular hypertrophy. This is a long slide, isn't it? Oh my goodness. Now the most common cause is hypertension, left ventricular hypertrophy, atrial systole into a stiff, non-compliant ventricle. Normally the left ventricle goes in and it relaxes, the left ventricle just sort of relaxes and floppy, relaxes and floppy. But because the left ventricle is unable to relax, bang, and it hits with a slam into the ventricle. S4 gallop is atrial systole into a stiff, non-compliant ventricle and hits with a bang. So that's S4 gallop. Now there's no additional therapy because of the S4 gallop, and hypertension has to be treated anyway. So therefore you just have to know, what does it mean? It's a much more important thing for boards than in life because we're focused in real life on what changes therapy. That doesn't change therapy. So we cool, leave it alone. A soft S1. What's causes a soft S1? It's the diagnosis when there's a soft S1. And the soft S1 is described in the question, what are you going to think about? You could be thinking about mitral regurg, because you have a pansystolic, holosystolic, tricuspid regurg, pansystolic or holosystolic, myocarditis, which infects the heart and just makes a soft S1. These conditions all are things that cause, they're all part of regurgitation that smooth out and smother out and obscure the S1. That's all you're going to get. It's going to just clog it off. No big deal. Leave it alone. Next, what is squatting and standing? Let's be 100% clear. When we squat, we're squeezing on the leg, vein. We squeeze up the blood into my heart and squeeze up, fill up the heart. Standing empties the heart. The effect is to increase venous return, decrease venous return. Increase venous return, decrease venous return. And anything that increases venous return to the heart will make all left-sided lesions louder except for hypertrophic obstructive cardiomyopathy and mitral valve prolapse. Because squatting increases the venous return as you compress those capacitance vessels of the legs and pour blood into the heart. And therefore, now the reason we're bringing this up again is sometimes people get mixed up by being told in medical school about the tetralogy of Fallot. The tetralogy of Fallot, and they go, oh, look at that little boy. He squats and he runs, and he squats and he runs, and he squats and he runs. And that's because of people thinking about increased loads and increased pressures elsewhere. That's not the main effect of squatting in the healthy normal adult or the general adult or the person who just has valvular lesions. The effect of squatting in those leg veins is to increase venous return to the heart, squeezing blood up from the legs into the heart. Now, standing opens the capacitance vessels of the legs and does the opposite, so it decreases venous return, and all lesions become softer except HOCM and mitral valve prolapse, with standing softer, less return, less blood, less murmur. Now, all murmurs increase with increased flow and return except HOCM and mitral valve prolapse. Now, squatting or leg raising are essentially equal. They're the same thing. Saying, how do I increase venous return to the heart? Well, they're both about the same. Now, our next slide, a thrill. What is a thrill? Interesting name, right? Thrill is a palpable murmur. When you see a thrill, it means evil, bad, really severe murmur. Okay? It's an extra fluid wave. This is cardiology. So the most accurate test is the echo. Transthoracic burst and transesophageal better. Catheterization technically is single most accurate, but not necessary, 99%. We want it to be repetitive so that you get it stuck in your brain like a fecalith in your circle of Willis. There's a fluid wave, yeah, ha ha! And it's such a wave, it's causing a thrill. And here, the thrill is a palpable murmur. It's a vibration from that turbulent flow. Reynolds number, remember high Reynolds number? Because this is both increased volume and increased velocity. And remember, a thrill is always pathological because a thrill always means severe, severe murmur. And it's felt by very lightly touching. You feel it? Lightly touching, you feel the vibration. You will probably never feel a murmur with a thrill in your life because those murmurs get replaced, those valves get replaced right away. Because if you've got a murmur that's so severe, that's level 4 out of 6, a 4 out of 6, 1 out of 6 only with maneuvers. 2 and 3 over 6, a little subjective. 4 over 6, you got a thrill. 5 over 6, you can hear it with the stethoscope off the chest. 6 over 6, you don't even need a stethoscope. Most of you here will never hear a 6 out of 6 murmur once in your life, and the murmur grading is incredibly subjective because there's no objective demarcations between a 2 out of 6 and a 3 over 6. Mostly it's like this. 5 out of 6 and 6 out of 6 can be heard by people's relatives. 4 over 6 can be heard by the medical student. 3 over 6 can be heard by an intern. 2 over 6 can be heard by a resident. And 1 over 6 murmurs, graded murmurs, can be heard by the attending. So Reynolds number means that you've got such high velocity, high diameter, as to hear the turbulence, the turbulent flow, the turbulent flow, the turbulent flow, the turbulent flow through that heart. The thrill means that you have a very severe murmur, so severe that you've got to replace the valve or sew it shut. Any murmur that is sufficiently intense that is associated by a thrill must get fixed right away surgically. The most accurate test is echocardiography. Here's another measure of that Reynolds number. A unitless number, our friend, the Reynolds number, and that's the unit. Above 2,000 means severe turbulence. Below 2,000 is minor turbulence. The Valsalva. The Valsalva is exhalation. It's alphabetical. That's right. That's why it's like this. Where the V is. That's good, right? It means you're almost done. So Valsalva is exhalation against the closed glottis. The pushing that you would do when you're trying to poop. The pushing you would do when you're trying to give birth to babies. Exhalation against the closed glottis increases the pressure in the chest. And therefore, it is a maneuver that decreases venous return. It is used to be able to say, do you have a murmur? Most murmurs will decrease with Valsalva except mitral valve prolapse and HOCM. When you can see this in the question, it is auscultatory lesions, AR, MR, AS, MS. And Valsalva in the physical exam maneuver, you're exhaling against a closed glottis, and basically it assesses the difference between HOCM. Now that we're at the end, of cardiology, I will tell you the single most commonly asked questions. You, O seekers of truth and knowledge, who have persisted to the end of the cardiovascular section, I will now give you the secret answer. The question is, Valsalva most useful for telling HOCM from aortic stenosis? Hypertrophic obstructive cardiomyopathy, crescendo decrescendo, aortic stenosis, crescendo decrescendo. And Valsalva most useful for distinguishing between those two murmurs. That's why. Valsalva, decreased murmur of aortic stenosis. Bear down, baby. You look at this guy's like in a permanent Valsalva, don't you think? Okay, and the Valsalva will decrease blood going into the heart, which results in a tachycardia, because since you have decreased stroke volume, you increase the rate. Decreased stroke volume, you increase the rate. Decreased stroke volume, you increase the rate. And most murmurs decrease in intensity and loudness. How do you expect blood to return? Oh yes, that's it. That's it. That's the Valsalva too. And so all murmurs decrease in intensity with this, except for this, and this is the answer, HOCM AS, as the single most important thing that you use for the Valsalva to tell the difference. What is the single most important use of these maneuvers? HOCM versus aortic stenosis. When the murmur increases with Valsalva, it's hypertrophic obstructive cardiomyopathy, because anything that makes the heart smaller increases the obstruction. Smaller increases the obstruction. Smaller increases the obstruction. Smaller heart, increased obstruction. Bigger heart, less obstruction. Small heart, big heart. Oh yeah. Okay, my goodness, some legs were meant to be covered. It's varicose veins, and when you see varicose veins in that story, they are caused by standing in your legs without moving enough. And they are basically treated by either stripping them out or sclerosing them. The fancy thing to do these days is you put a catheter into those veins and put a sclerosing agent into them that literally dries them up and shrivels them up. Varicose veins are caused by incompetent valves, leaky valves in the saphenous veins. So they dilate. Those leaky valves in the saphenous veins dilate. And patients, it's not just cosmetic. These people, their legs hurt, man. Their legs hurt. Their legs hurt. They hurt because they're swollen, because they're dilated, and they have a dull ache in the legs worsened by prolonged standing, and they get better with elevation because you drain out the leg veins. And remember, severe disease gets associated with ulcers and bleeding and infection because you can actually break down the skin. It can get so bad as to actually break down the skin of your leg veins. So the varicose veins here, ultimately, it's a dilation. The blood, and remember what we said about the law of Laplace? The more it dilates, the more it's going to dilate. Law of Laplace. The more it dilates, the wider it gets, because it actually increases the wall tension. Oh yeah, as it dilates up. So the discomfort, you elevate the legs drain out, or you sclerose them out, or you compress them with venous compression stockings. And surgical removal is very difficult, but I would do it. Man, I'd do it in 2 seconds. I don't even show my legs. I rarely wear skirts. I have a lot of hair on my legs, so you can't even see too much. But the small ones are injected with a sclerosing agent to dry them up and shrivel them. And when you inject them up here, oh my goodness, you inject them, they shrivel, goes away. You feel good about yourself. Keep your legs in the air. There you go. What is this? Yeah, I know it's an ankle. Do you know what that discoloration is? That discoloration is blood pigment in your skin. That's what this discoloration is. This discoloration is blood pigment in your skin, hemoglobin in your skin. It's like tattooing. These are venous stasis ulcers, and this is chronic venous insufficiency. And there's chronic venous insufficiency. This chronic venous insufficiency results in extravasation. Results in extravasation of blood and the hemoglobin pigment staining the skin. And the venous stasis is occurring in the elderly with chronic venous insufficiency, and the hemoglobin stains the skin, and you really can't do anything about it except to correct the underlying cause. And you can't do that so well except to say, exercise, move your legs. I stand up most of the day. How come, actually, except for the fact that they're very hairy, I happen to have beautiful legs. I do. I mean, except for my big knees. I mean, actually I don't. But the thing is, they may not be beautiful, but I don't have any veins visible. How come I don't have any veins visible? Well, besides the hair. And the answer is because I'm moving all the time. That's why. I'm moving all the time. You see, this hyperpigmentation is because the blood leaks out, and then you really can't do much of anything about it. It's oxidized heme. It cooks it. Venous stasis ulcer is very straightforward, and very straightforward means lose weight and move. 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 I like to move it, move it. You like to move it, move it. We like to move it. Diabetic ulcers break down and they can go into the bone. Those venous stasis ulcers are a disease of the elderly, a condition of the elderly, and a condition of obesity and diabetes. The treatment, here's a long line, but it basically says elevate your legs, move, correct the infection, use compression stockings, and correct the underlying cause. Ultimately, if nothing else works with it, you have to bypass the arteries to increase the supply to the legs. That's it. All right, almost down to Dwyer for cardiovascular. And a heave or a lift. The heave and the lift is you put your hand on people's chests to actually feel the movement of the heart in the thorax. Wow, people do that? Yeah. You can actually feel it. And when you see and feel the hand pushed by the chest, it's a sign of a ventricular hypertrophy, cardiomegaly. When a heave or a lift is in the question, you should be thinking of cardiac hypertrophy, a big, big heart. Here's a colorized x-ray. Very beautiful, don't you think? And the heave or the lift, the hand gets pushed up because the ventricular hypertrophy moves it out of the way and increases from diastolic filling or simply just a big heart. When you see a heave described in it, it means ventricular hypertrophy. It can be left ventricular hypertrophy. It can be right ventricular hypertrophy. But left ventricular hypertrophy is to the side and the back. Right ventricular hypertrophy is in front. The right ventricle. Now, 75% of the anterior surface of the heart, most of the anterior surface of the heart is right ventricle. Most of the anterior surface of the heart is the right ventricle. Most of the anterior surface of the heart is the right ventricle. And that gives a heave forward. And left ventricle is, as the name would say, on the left. A heave ventricular hypertrophy. Oh, a water hammer pulse. As if anybody even knew. What is a water hammer? What's a water hammer? Well, to be precise, a water hammer is a leftover from pre-steam engine times. How did you do industrial building when you didn't have electricity? And you didn't have a steam engine. Steam engine, though, is, 1820s, 1830s, 30s, 40s. But the thing is that the water hammer would be that the water would lift up the hammer, and then it would bang, lift up the hammer, bang. So a water hammer pulse is a water hammer would go bounding up, bang, bounding up, bang. And that's what a water hammer pulse is. When you see this, it's a high bounding pulse. It implies a very big pulse pressure. The big pulse pressure, the diagnosis associated with it is regurgitation. And this is the cardiac section for pulses, so it's actually not an angiogram. It's looking at the heart with an echocardiogram. Even though the high bounding pulse is in the carotid, what we're going to look at is the ventricle, because the large stroke volume, boom, expecting it to regurgitate back down. High stroke volume, boom, expecting it to regurgitate down. And that's the water hammer pulse, followed by a rapid runoff. There we go. The difference between a normal pulse and the high bounding pulse of the water hammer or Corrigan's or collapsing pulse. And it is a sign of aortic regurgitation. Splash! Up, down. Oh, look at all the big filling, excess filling, excess filling. Remember mitral stenosis only went up to there? Excess filling, splash! Because it's going to be wasted. It's going to go backwards. It's going to go backwards. Use a big up pulse, because it falls back down, doesn't it? So water hammer pulse is aortic regurgitation. Now, hyperthyroidism in various hyperdynamic states where you're going to have a lot of loss, a lot of waste. It's like a military budget. Squared out a whole lot extra, knowing that about half of it's going to be wasted. The most accurate test is echocardiogram for this very high bounding pulse from big stroke volume. Remember, in aortic regurg, you're expecting to have an excessively increased ejection fraction, knowing most of it's gonna be wasted. Now, the wide split, we are down the end. Wide split and paradoxical S2. No human being can hear this. I can't. I try. Maybe I can hit a wide split. I'm trying. What's it mean? Wide split, paradoxical split. And when you hear that split, what's it mean in the history? What causes it? Well, the S2 has A2, B2, A2, B2, aortic, pulmonic, wide split, aortic, pulmonic. Wide split, aortic, pulmonic. So it's split, and the aortic normally should go first. Why the aortic first? Why the aortic first? The aortic goes first because of pressure. The aortic is first because of pressure, extra pressure. Because what pushes valves closed? Pressure. Which one has a higher pressure? Aortic. So the S2 has a slight variation, 1/10 of a second, where the A2 precedes the P2. Very close, because there's a little difference in pressure, which is exaggerated by wide splitting. With what increases the pressure, delays the emptying there? Pulmonic stenosis, pulmonary hypertension, paradoxical split. Paradoxical splitting of this is the exact opposite. Wide splitting, pulmonic stenosis, pulmonary hypertension, right bundle branch block delays the P2. What delays the A2? Well, if pulmonary hypertension, pulmonic stenosis, right bundle branch block delay the P2, it must mean that hypertension, aortic stenosis, left bundle branch block delay the A2. Let's look at the split. Wide split delays the P2. Pulmonic stenosis delays the emptying, delays the closing. Pulmonary hypertension delays the emptying of the right side of the heart, delays the closing of the right heart. Delayed emptying, delayed closing. Delayed emptying, delayed closing. Ooh, that's a beautiful slide of pressures. I want you to pause on that and absorb that because it's going to help you to understand why the right side of the heart. See, what I want you to get out of that slide is simply understanding that the right side of the heart should fill more when you inhale. The right side of the heart fills more when you inhale, and the left side of the heart fills more when you exhale. So let's do that again. Oh yes, beautiful. I love it. That's such a beautiful picture. I can't stand it. It's so pretty. Wide split is caused by delayed emptying the right side because it's delayed electrical stimulation. Pulmonic stenosis, delayed emptying, delayed closing. Pulmonary hypertension, delayed emptying, delayed closing. Paradoxical split, the other way around. What delays the aortic emptying? Left bundle branch block. What delays the aorta emptying? The left ventricle emptying. Aortic stenosis. What delays it? Hypertension and hypertrophic cardiomyopathy. Look them up. It's not going to change. Physical findings don't change. That's why we're doing these with lots of images. And if we tried doing it with this number of images in a slide deck in a physical flashcard, you'd have to make 750 cards. Here you can just say, I've seen everything, and you're done. Yes, you are. See you soon.